Good morning. Welcome to Room 1 at the Mount Sinai Fuster Heart Hospital CAS Lab. I am pleasantly honored to have everybody here, including Dr. Moreno to my left, Mariella Drosu, our interventional fellow, to my right. My name is Joe Sweeney. I'm one of the faculty members here at Mount Sinai. And this is our second annual case, or second case of the year, of CFT Live, so Coronary Function Testing Live. And the goal of this case is to really hammer down the procedural aspects of performing coronary function testing, why we do it, how we do it, and most importantly, how it changes our treatment for these patients. So today's case is a 67-year-old female with prior COVID and persistent exertional chest pain. As I mentioned, my name is Joe Sweeney. Dr. Moreno's to my left. I'm honored to have Dr. Samit Shah, who comes to us from New Haven, Yale, who's the director of the VA CAS lab there, assistant professor of medicine, and is the lead investigator in one of the largest American prospective registries of patients with non-obstructive coronary disease and angina. And with that, I'll turn it over to Dr. Shah and Dr. Sharma.
Okay, good morning to our CCC Live audience, and great addition to our CCC Live. As you know that we have been doing a CCC Live coronary cases since July 2009. Then we added endovascular in 2013. Then we added structural cases in 2016. So every week we had the cases, and now question was what to do on the fourth week, which is usually the first week of the month, because we have second, third, and fourth. With your strong demand, so I'm so happy that we starting the new series, which I mentioned last month, with the imaging, because we felt that what else can we add to our audience. One was the imaging, focused imaging. So that was the done CCC Live imaging case done by Dr. Keeney. And then there was a lot of interest on this normal or non-obstructive coronary artery disease, but patient continues to have chest pain. Many studies have been done. So the whole field of coronary functional testing, the microvascular testing, and and clearly with Joe Sweeney being the expert, and we have the commitment to do those cases regularly. So what will happen now, that every other month there will be a coronary function testing live will start, and preferably will be on the first Wednesday. It may change based on some other schedules, but that's what we'll keep it. So every time is consistent. But more important to all of you, our CCC Live viewers, to keep us very positive, and such a big audience of 25,000 per month in 190 countries. I don't think any activity in the world has that every month hits. So once again, thank you. Be very interactive. Ask the questions. And to lead this pack today, we have the expert, Dr. Samit Shah, who is the expert in this field. So he'll take it from now. And I wish all of you good luck and very interactive session.
Okay, so going forward, just some background. So our target audience in this educational endeavor, is really designed for interventional cardiologists, clinical cardiologists, any healthcare professional involved in managing patients with angina and non-obstructive coronary disease, otherwise known as ANOCA. What we feel is there are practice gaps that help to identify the appropriate patients that should undergo invasive coronary function testing. We really need to review the procedural aspects. We need some homogeneity in how we perform these procedures amongst these patients. And then really importantly, how we interpret these results to further classify patients into specific ANOCA endotypes. And it's those endotypes that really help guide our treatment for these patients. So the learning objectives today is to really review some of the clinical evidence supporting the use of coronary function testing, review all the procedural aspects step by step on performing it, including the anatomical, endothelial, non-endothelial mechanisms at play, and then apply the results of up-to-date clinical trials to treat this patient population. I'd be amiss if I didn't say we do have commercial support to help with this educational activity through Abbott. We do use some devices that are off-label, and I would defer to the prescribing information for each product that we use. So this is our case. So this is a 67-year-old female. She carries cardiovascular risk factors, which include a postmenopausal state and controlled hyperlipidemia and hypertension for the past 20 years. She's a home attendant, she's single, she does not smoke. She had a father with hypertension and an undiagnosed cardiomyopathy. Her BMI was 23, her A1C is 5, an LDL cholesterol of 85, C-reactive protein of 0.8, and a serum creatinine of 0.8. Her current medications include aspirin, bisoprolol, atorvastatin, ranolazine, and valsartan. Her clinical presentation started in 2020, where she was diagnosed with a COVID infection. At the height of our pandemic, she recovered from that. It was a mild infection. She did proceed to have 3 vaccinations for COVID and stopped after the 3rd, but she did develop a repeat COVID infection in March of 2023. This infection was severe. She did not require hospitalization, but she had a very high fever, severe pain, significant shortness of breath, and chest discomfort. She did require supplemental oxygen for that episode of COVID. After she recovered from COVID, she developed CCS class 2 anginal symptoms. Her cardiologist at that time was concerned and eventually led to a left heart cath in June of 23 that showed normal coronaries. Since June of 23, she's been to the emergency room twice with recurrent chest pain symptoms. Did not repeat a catheterization, but did undergo usual rule-out testing in the emergency room and eventually sent home. She was followed by her cardiologist for this chest discomfort because it persisted, and eventually underwent a stress test in August of 23, where she exercised for 10 minutes, 20 seconds. She did not have any angina on the treadmill, but she did have she did not have EKG changes, but she did have an abnormal perfusion study with a moderate ischemia in the inferior wall. Based on this and her persistent symptoms, a little bit later, her cardiologist performed a coronary CTA. And this showed a mild non-calcified plaque in the mid-RCA, a patent coronary arteries without any evidence of plaque or stenosis in the left dominant system, and a normal coronary calcium, or calcium score is 0. So given that information, her cardiologist treated her for presumed coronary microvascular dysfunction and started a therapy of ranolazine and bisoprolol. She continued to have symptoms, and her symptoms actually progressed now to CCS class 3. And so here we are, the plan today. She was referred for comprehensive coronary function testing, and that is the plan today. So before we do that, I want to take a second to review the angiogram that we did today. If you guys can show the angiogram. So this is the LAO-caudal view. You see very large vessels, large left main, large left circumflex. Next. Ariocaudal view, again, you see a significantly large left circ and a large LAD. And here's your cranial picture, very large LAD. You do note some tortuosity in these vessels, which is interesting. Next. And this is our LAO-cranial, which helps define our dominance. Again, a left dominant system. Her LV function was normal, the end diastolic pressure was 15, and this was a non-dominant RCA. So that was her angiogram just done now. If you can go back to the slides. So I want to start by taking a step back. After COVID, we saw an enormous influx of literature that surrounded testing patients with COVID persistent chest pain for microvascular dysfunction. And by and large, not all, but most of these studies were non-invasive assessments, PET scans, MPIs. Very few, actually Dr. Shah was one of them, one of the physicians that did a case series in doing invasive testing in patients with COVID and ANOCA. But when you have the amount of information and literature that came out from this, there was an immense amount of heterogeneity in how these patients were managed, how they were tested, when they were tested, and so it created a lot of confusion. And it included factors such as the time interval when they had COVID to when they were tested, what modality was used, was it PET, was it CMR, stress, and what was the severity of the COVID infection. A lot of variables created to a lot of variability in the data that came out. And like I said, majority of them were assessed non-invasively. And the issue with assessing coronary function testing non-invasively is you miss something we call an endothelial dependent mechanism, such as vasospasm, because you're not able to do that. You can do it, but most centers don't do cold water testing. So what we do know that came out of COVID is the acute COVID cardiovascular manifestations really present with myocarditis, acute coronary syndrome, STEMI, arrhythmias, vascular endothelial dysfunction, and vasospasm. And 91% of those patients with persistent viral symptoms in the acute phase had an acute cardiovascular manifestation. And 35% at 6 months had persistent chest pain. And the thought was, does this represent coronary microvascular dysfunction? The question is, what are the longer term manifestations? Does chest pain extend out even to this duration, such as this patient? Looking at the microvascular state and what the actual virus does, there's a nice term out there called virus-related endotheliopathy. And this is coronary microvascular specific. And the thought is that this virus caused a disarrangement in the local renin-angiotensin system. It caused obstruction through inflammation, prothrombotic state, and microthrombi. It caused hypoxia or through the lungs, and in so doing, it caused oxidative stress, which then altered the supply-demand mismatch of the coronary bed. And it also caused autonomic nerve dysfunction that altered the coronary blood flow. And I'll point your attention to the lower right. This is a diagram of the endothelial cell, and I think it's a very, very descriptive diagram. And on the left cartoon, this is a normal functioning endothelium. And in a normal functioning endothelium, acetylcholine binds to a muscarinic receptor, and through intercellular signaling, it activates the endothelial nitric oxide synthase, thereby producing nitric oxide, which is a soluble gas, diffuses through the membrane to the vascular smooth muscle, and by doing so, it prevents or it increases the calcium uptake into the vascular smooth muscle and out of the intracellular space, promoting vasorelaxation. Now take to the cartoon to the right, and when your endothelial is dysfunctional, you have an uncoupling of that nitric oxide synthase, so you actually form less nitric oxide. And then when you have less nitric oxide, that ability to reuptake calcium is diminished. Therefore, you have a heightened vasoconstriction because of the calcium in the space. It's important to understand this because any observation after giving acetylcholine that is not vasodilatation is actually abnormal. So it should vasodilate in a normal functioning endothelium. And I want to keep that in mind as we do this today. So I want to touch on a couple of things with the ANOCA and the COVID infection. This is one study that looked at coronary function testing in 140 patients. 20 of those patients that were studied actually developed COVID after they were enrolled in the trial. And all those patients underwent coronary function testing. Their average age was 56, predominantly female. The time to testing was almost a half a year. The time to testing was about a half a year before they were, since they were symptomatic. Almost 80% had an abnormal stress MPI. And 100% of those patients that underwent testing had endothelial dependent abnormalities. So meaning they had vasospastic provocation, which is very interesting. And 50% of those patients had endothelial independent dysfunction. So that's microvascular dysfunction that we test with adenosine. So bottom line is ANOCA is very, very prevalent in this population of the long COVID patients, and it's predominantly characterized by epicardial and microvascular vasospasm. Obviously, this was an observational trial. It was very small, but it really shed a big light into what was going on here. So what is our protocol for coronary function testing? Well, we have a patient with chest pain, maybe some EKG changes, some abnormal, non-invasive study, but normal coronaries. What we want to test, we want to undergo coronary function testing to help identify an endotype. And those endotypes include vasospastic angina, and we refer to that as a dependent, endothelial dependent endotype. We want to test to see if they have coronary microvascular dysfunction. That is a non-endothelial dependent endotype. And then more recently, we're starting to test more and more for myocardial bridging, which is also part of an endotype. And we do that through imaging and dobutamine and FFR. So the protocol is we do a diagnostic angiogram, we then go up with a guide, and then we actually proceed with acetylcholine infusion through the coronary guide into the left system. And we test, we infuse for about a minute, and then we test an EKG, and then we repeat an angiogram looking for angiographic symptoms of spasm or evidence of spasm. We do that through serial dilutions of acetylcholine, and then we reverse it with nitroglycerin, and then we proceed with our non-endothelial dependent mechanism testing with adenosine. We induce hyperemia, and then we drop down a coronary flow wire, which measures our transit time of the coronary flow before at rest and with hyperemia. And that allows us to test the microvascular resistance. And then if there's any evidence of angiographic bridging, we then would proceed with imaging and then doing dobutamine FFR or RFR. Our acetylcholine is provided by us through our pharmacy. We have a great working relationship with them. It comes as an ocular formulation called Myocol. We proceed with doing a 20 microgram dose. That's the endothelial dysfunction dose. And then we ramp right up to 100 microgram dose. We infuse it over 1 to 2 minutes, and then again we take pictures in between with an EKG and then reverse it. This is what a lot of people don't understand is actually a very safe procedure. There's one trial that looked at over 71,000 patients. The overall risk of adverse events in this is less than 1%. And persistent vasospasm, very, very low, less than 0.1%. So it's a very safe procedure if it's done with the right methodical procedural aspect that we try to teach here, and a lot of centers that do it in the country. You can go up the guide if you want.
Yep.
So there's one aspect that always comes up that we're asked about, which is how do we know if a patient's having spasm? And the prognostic significance of spasm has been studied pretty extensively through the COVADIS registry. This is a registry in the Netherlands that looked at how, when you induce vasospasm, they require 3 criteria. Number 1, they have to have ischemic symptoms. They require EKG changes, ST elevation, ST depression. And number 3, they have to have evidence of epicardial spasm, which is greater than 90% angiographic spasm. And it's very unclear in some of our groups that we talk about this. Sometimes we have one of those, sometimes we have none of those, sometimes we have 2 of those variables. And one of our colleagues, Nat Smilowitz, brought this paper to my attention, which I think is just fantastic. This looked at 500 patients using the COVADIS criteria and risk stratified based on the number of criteria present. And it actually is very predictive. The more criteria you have, the more predictive you have of MACE. So if you have no criteria, your risk of MACE is very low, 3%. If you have one of those 3 criteria, you're at 9%. 2 of those criteria, 10%. All 3, 15% risk of major adverse cardiovascular event. So this was actually very helpful to us because we don't really have to hang our hat now on having all 3 of those criteria to help say this patient has vasospasm. We then switch our attention to the non-endothelial dependent. We do this through the CoroVentus wire, which is made by Abbott. And this, we put a wire down the LAD, and we give Salus Boline injections. And those Salus Boline injections are timed through a temperature pressure sensor on the wire. And you see it rests in the blue curves. And then we induce hyperemia, and those are the orange curves. And then through that, this software provides us with coronary function reserve It provides us of an index of microvascular resistance. It provides us with a resting full cycle ratio. And all that comes up in a nice user-friendly screen. And there are set cutoffs for each of these. A normal CFR is anything greater than 2.5. And a normal IMR is anything less than 25. So this is actually now, this is the second part of the CFT testing where we give adenosine to induce hyperemia. And then lastly, what we try to teach is you have to be very, very methodical and attentive to how you're doing these injections. And you want to have consistency. And this is a nice slide provided by Abbott. They use an acronym CAF-CMD. So you want to have correct catheter engagement. You want to advance the wire at least 6 centimeters down the LAD. You want to have a target heart rate with hyperemia. You want to inject flows so they're consistent. You want to see the curves almost superimposable. And then you want to calculate the coronary flow reserve, or it does it for you, and the microvascular resistance, and then you come up with a diagnosis. So it's actually a nice slide that helps summarize really the overall scope of what we do with the adenosine testing in CoroFlow. And then my last slide before we get to the testing is looking at some of the variances that we get with the non-endothelial adenosine testing. And some of the confusion that comes is how do we interpret low CFR, high IMR, and vice versa? And what we've seen is there's some nomenclature out there now termed functional and structural coronary microvascular dysfunction. And a functional coronary microvascular dysfunction is, by definition, a low CFR, but with normal microvascular resistance. And this can be from a state of an increased heightened myocardial demand, dysautoregulation that causes a resting elevated coronary blood flow. And remember your CFR, if your resting blood flow is high, the transit time is going to be low, and that lowers your, or lowers your CFR, and your CFR is going to be coming out as abnormal, but it's because you have a low resting coronary blood flow. Versus a structural coronary microvascular dysfunction is a low CFR and a high myocardial resistance. And this is more related to architectural changes in the actual microvascular bed. Rarefaction, obliteration, hypertension, high afterload. And this trial, the Elias Registry, looked at these two aspects of structural versus functional. And it's by far the CFR that drives the outcomes here. So you see the MACE and the target vessel failure and MACE are heightened in those patients with low CFR versus those patients with a normal CFR. Whether it's functional or structural didn't really make a difference. They both had equal poor outcomes. So with that, I'm going to switch to our case now and get some comments from our moderator, Dr. Shah, as we engage our guide. Samit, what do you think?
Yeah, Joe, thanks so much for having me. This is great. And the case is really typical of the cases that we're seeing. This woman has had a pretty extensive workup, including a prior cath, a CTA, a stress test, and has ongoing symptoms. And so she's lucky to have you and your team available to do this testing because it's becoming increasingly important.
Yeah, thank you so much. So we're going to start with our acetylcholine. So we run a 12 lead EKG. You want to just tap on fluoro? Mm-hmm. If you want to put the letters up. So our protocol here is we use a manual manifold. We try not to use the assist. And you can see our guide picture here. It's actually a nice LAD, some tortuosity to it. It is a left dominant system. Sumit, I'm curious about what your experience with left dominant systems and acetylcholines is. Acetylcholine?
Yeah, I think you nailed or hit the nail on the head when you said that this is safe, and we've seen this in our own experience, that even with left dominant systems, when you have diffuse spasm, patients tolerate it fairly well. Yep. But we haven't really seen adverse effects from right versus left dominance. Yep.
Now, Samit, when you're doing it, are you doing one vessel, two vessels, three vessels, LAD, RCA? We tend to focus mainly on the LAD here.
Same. So we bolus our acetylcholine in through the guide in the left main, just as you're doing.
Yep.
I think you and I had talked about how initially when we started doing this, we used a microcatheter,
Yeah.
similar to what some of the older trials had done. But really, the guide is the most efficient and probably the safest way to do this in our experience. And then we do our wire-based testing in the LED almost 100% of the time, unless there's a compelling reason to do it in another vessel.
Sure. Okay, so what I've done is our acetylcholine, we start with a 20 microgram dose. What I do is we park it into the guide. It does not go into the coronary yet. It's a 3 cc bolus or volume. I then am going to displace that with a 10 cc syringe of saline. And my protocol is I try to do this over a minute. At the same time, I'm running an EKG. The most common side effect we see here is bradycardia, sometimes a pause. But we start with a 20 microgram dose, and if you can start a timer. Again, what I'm doing here is really just displacing what's in my guide. So the guide volume to the stopcock here is about 4 cc's. So I know once I'm at 4 cc's in, my acetylcholine is fully delivered to the LAD. And I do it slowly, watching the EKG as I do it.
And Joe, how often do you see significant arrhythmias, Brady or tachy?
Probably the bradycardia is, I would say, probably less than 10-20%. We've seen a couple of AV blocks. I've had one case of AFib, very transient, but pretty rare. And it's all based on your infusion rate. If you see it, if you see bradycardia or you see a block, you slow down. And then you restart.
Here, Pedro Moreno, thank you so much. So the other issue with the EKG is to keep an eye on your ST segment. And also the patient may tell you that she's starting to have symptoms. With a 20 is unusual, but I had a case actually with non-obstructive mid-LAD that developed a severe spasm with the 20. And you can even have, slow flow. So you have to be very meticulous on these.
Yeah, Pedro, I agree with that. And I think it's important that you stay, just like you said, on your A game, watching the EKG the whole time. And I had a case just this week that also spasmed at 20 micrograms. And so it's never a guarantee that this low dose isn't going to have an effect.
Okay, I'm 5 cc's in. So at this point, I'm pretty confident that my acetylcholine is in. Now, one thing I do teach my fellows here is that I aspirate before I give the guide injection. So I don't want to bolus acetylcholine with a guide injection with a dye, and that's why I do that. It's more important at the 100 milligram dose, 100 microgram dose than the 20, but it's kind of good practice. Again, the risks of acetylcholine are really rate dependent and dose.
And what's your sedation strategy for the patient? Do you keep them awake or are they sedated?
So we'd love to have patients awake, but we do provide sedation through fentanyl and Versed in that combination.
Yeah, we do the same, and I don't think it's changed our yield of spasm. We still see quite a bit.
Hold on.
You tell me.
Okay, do an EKG, please. Okay, we don't see any EKG changes. And I think what's important is, Sydney. Is EKG changes. When I first started, I was looking for ST elevation. And that's only part of the story. You can have ST depressions. And that's a positive EKG finding.
Yeah, that's right. And the EKG placement with somebody on the table isn't always our standard 12 lead. And so I think ST depression is definitely part of it, and partially because of the localization of the leads.
Yeah, and also, what we say a lot is you were dealing with a patient that's sedated. Are they going to be able to experience chest pain? Hard to say. 100.
Just to keep going with the procedural, most importantly, you should hold all the vasodilators be at least 24 to 48 hours before. And the audience may ask, why are we doing radial? I'm sorry, what are we doing femoral? And the answer is because of the propensity to spasm with the radial approach, we prefer doing femoral, but it's operator-dependent, decision.
Yeah, we started doing radial, and when I do it, I avoid giving verapamil. I won't give nitro either. If I do have spasm, I'll give a little nitro, but then I'll wait. Probably 10, 15 minutes before I do any provocative testing.
Yeah,
Sumit, are you doing radial or femoral?
Yeah, we're about 85% radial for these cases.
Yep.
We don't use vasodilators, but I actually don't think it affects anything if you give a little radial nitroglycerin.
I think you're right. I think you're right.
Okay. Yep. The other thing, sometimes in the diagnostic, the fellow may actually induce a severe spasm in the RCA, and you need to give nitroglycerin. So you do your microvascular testing first. You wait at least 15 to 20, 30 minutes to do your acetylcholine. So don't get desperate if you have a bad spasm induced by the catheter.
Now the
Yeah, that's
question
a great point.
is that predictive of provocative spasm?
Yeah, what do you think? My bias is no. I think it's a mechanical thing from
I
catheter
completely
spasm.
agree. We agree. And that's our experience here, is that we proceed. Now, the one aspect is a left main spasm. I don't know.
Yeah, and again, I think it's safe to give some nitroglycerin and wait.
Yep.
And as Dr. Moreno said, just do your wire-based testing first, and then you can do your acetylcholine after that.
Yeah.
Yeah, the other comment that I want to ask is, what about testing acetylcholine in patients with atherosclerosis that is non-obstructive versus totally normal course like this? How do you interpret that?
I think that atherosclerosis is one of the biggest risk factors for spasm. I think myocardial bridges and atherosclerosis are the two main things that we see when patients have profound spasm. They're usually not totally normal coronaries. And so I think part of it is endothelial dysfunction, but we also actually see significant spasm.
Very good.
Sumit, I'm curious what your thoughts are on the Elias registry with those, the three variables, kind of teased out, and the prognosis of having 1, 2, or 3.
Yeah, and I wonder if it speaks to the magnitude of spasm. So, like in this case, for example, if she has epicardial spasm, some chest pain, but no EKG changes, I wonder if that's less significant than somebody that, for example, had ST elevation along with the chest pain and epicardial spasm.
Yeah, I think in that the biggest driver was an epicardial spasm.
Yeah.
Angiographic.
Yeah, and that makes sense. I would love to see, I have to go look at that paper to see what their MACE definition was, because my experience with these patients is that they're usually not having MIs and hard cardiac events. It's a symptomatic disease where they're coming back to the hospital for chest pain.
Yeah, that's a very good point. Okay, so we are now displacing 100 microgram dose. So this is our vasospastic dose, and I've displaced it about 5 cc. She's tolerating this actually quite well from at least an EKG perspective. I haven't seen any block, a little bradycardia, but nothing bad, which is great.
Do you increase the rate with the higher doses, or do you stay the same 1 minute?
I usually stay the same. I try to do a minute. Obviously, if she has anything, I slow down.
The Cormica trial in patients where they didn't have a diagnosis at 100 micrograms would bolus in 200 micrograms.
Yeah, so that's a great question, and something that I was going to ask you. Are you doing 200 mics up front?
We do, yeah. So if we think that the patient's clinical syndrome fits, and we still don't have an answer, we'll do 200.
Okay.
But again, understanding that there's a potential safety risk.
So that's 100. That's pretty normal.
I think so. I think there's no significant narrowing or spasm that you see, and the flow looks about the same as when you started.
I agree. Sometimes what I will do is a caudal, so I'm not missing any Circ disease or anything like that.
Good.
Yep. Yeah.
Nice.
It looks good. Another very important aspect is nitro. You need to have nitro readily available. Our protocols, we fill 2 syringes of nitro. And then after we give the acetylcholine, we do at least 200 micrograms of IC nitro. Even if there's no spasm, I still give it.
And how much do you give?
I usually 200.
Yeah.
Okay.
No. Good.
The sequence that you're doing this is really efficient. You do your diagnostic angiogram, then the acetylcholine. You give your nitro, which sets you up to put your wire down next.
Exactly.
And these really aren't long procedures. They're actually pretty quick.
Yeah.
They're not. So now this is a very important part, is being able to do this wire. This wire is a little tricky, a little bit different than some of our other coronary pressure wires. You have to zero the system first, and then activate the wire.
The nice thing about the CoroFlow system is that it really tells you how to do it. It guides you through all these small steps.
It does. And then we'll turn the wire on. Yep.
I have an introducer then.
Are we able to see the CoroFlow screen?
Yes, absolutely.
Yeah, I think that's good.
This wire is very malleable, to say the least.
Yeah, it shapes very easily.
Yes, it does.
You have a sharp turn into your LED. Are you putting a secondary bend on it?
We might. We're gonna try to do it without, and if we can't, then we will. If we have trouble, engaging this wire, we will also put a buddy wire down. It doesn't affect the readings.
Yeah, that's actually a great point, and something that helped us a lot was just putting a second wire in to brace the guide.
Yep. Okay. So at this point, our wire introducer is out, Floral.
Mm-hmm.
And our wire is just at the outside of the left main. So this is where we equalize.
And it looked like you just flushed some saline in.
I did, just to make sure we didn't have any contrast in the guide.
Yeah, perfect.
Okay, we're at 1. We'll hold the wire.
So I usually go with my torquer, although I never use it for the usual PCIs. We use it for this because the wire sometimes doesn't obey. This is a little bit of a
little tortuous.
Yeah. Love to have a better curve. It's going into a septal.
Yeah, get a run through.
Yeah. Because the torque.
There's that septal
yeah,
right
okay.
there.
Let's do a little bit more. Yeah, we're good.
And I see that you've switched the CoroFlow to RFR, which is an epicardial index, a non-hyperemic pressure ratio. So do you measure that in every patient?
We do. Yeah, we do. The more data we get, the better we feel we're prepped. Here, let's go with the run through.
You might need more.
You need another wire introducer?
Yep.
Have another wire introducer?
Yep. There you go.
Thank you. So as you see, the tortuosity of the Prox LAD is not designed for this specific wire, so we look for another one that is a little bit more torqueable. In this case, we're doing the BMW, huh?
There's a run through.
The run through, I'm sorry.
Yeah, and with all pressure wires, I think tortuous vessels can be a challenge. I have not had many, though, where we can't get it down.
Yeah,
exactly. And so I think doing exactly what you're doing and just being strategic and using another wire to show you where to go.
There we go.
Okay.
Now that's septal. Better. That's septal.
Yeah, that's septal, yeah.
There you go.
Wow, big tortuosity.
Septal. Yep. Good.
All right, so we're done with the run-through wire. Very easy to go compared to the other wire.
Yeah.
All right, so I'm gonna go back with our FFR, IFR wire.
There we go. Beautiful.
Showed it exactly where to go.
Okay, good.
Okay.
So we like to do at least 6 centimeters. I think anything shorter than that, your flows are going to be, you can leave the run through in, but that's okay.
Yeah.
So the buddy wire actually does not affect the flows, which is an important thing. You can just leave it in, but if Dr. Moreno took it out, that's fine too. So I'm going to just make sure our guide is clear of air, and we'll cine that.
Okay.
Good.
6
So
centimeters
I
at least.
cine it so I know where my wire is.
Yeah.
And the reason why is I want to make sure I don't have wire drift, meaning the wire's coming back, the wire's going forward.
And you can tell that we might have some, pseudo lesions in the Prox LAD that is being straight up with the wire. But this is kind of unusual. And I was going to ask, there are so many now associations with FMD and tortuosity and female-related coronary non-atherosclerotic pathology. I think it's an interesting discussion there.
Yeah, it really is. This kind of anatomy, people have said that it's related to hypertension, but we clearly see it more in female patients, that the coronary arteries are tortuous, and we don't really understand how it correlates to symptoms or to presentations like your patient.
Great. We're going to focus on this part, which is very important for the audience, which is giving the flow baseline. So
Sumit, what we've done, so we are now going to do, so there's two ways to do this, measuring myocardial resistance. One is through a bolus saline injection, which is by and large what most of the country and the world is doing. But there is another way. There's the absolute microvascular resistance through continuous thermodilution, which is actually infused saline. We haven't really adopted that here, Sumit. I don't know if you have.
We haven't. We're going to, for clinical trial purposes, start doing it. But the challenge is that you need specialized equipment that's not reimbursed. And so you need a specialized microcatheter and then to connect it to a microinfusion pump for a saline injection.
Yeah.
So I think bolus thermodilution, the nice thing is that you can do this in almost any cath lab. You don't really need anything specific other than this wire.
Correct. So I did a test flow. So you'll see the CoroVentus screen on right now. And
So
what I'm doing is I'm waiting for the temperature to drop back to 0 and then to repeat it. And I'm doing a 1 cc injection.
You mean 3 cc, no?
Sorry, 3 cc's.
Yeah. So your first reading is 1.12, your transit time, and so these are your resting flows. Your second is 2.20.
Yep.
And so, do you keep these, or do you repeat them?
No, we repeat. We're looking for consistency. So the one test is, these curves look like it's probably on the slower side. You can get rid of the 1.1. And again, this might just be a function of, like I said, that slow coronary blood flow.
Right.
And given the tortuosity of this vessel. So my temperature is now back to 0. I'll displace 3 cc's as quick as I can. Okay, and we'll get rid of the 1.96. Those are pretty good curves. I'm actually quite pleased.
Those are great curves. Yeah.
So why don't we take them? We'll take
they're
those.
within 10%. That's perfect.
Exactly. So our resting transit time is 2 seconds. Now, in my experience, that's long.
Yeah, I agree. We looked at our
long.
data, and the median of ours is exactly 1. There's no standards that are published for what a resting transit time is, but I agree that this is certainly long.
But I think it's probably related to the tortuosity of that LAD.
What do you think about the size of her coronary? So we inject 3 cc's in every patient, but her coronaries are very large.
Very large. Very large. Go ahead and start a timer. So now we're going to induce hyperemia.
And how do you do that? What are you using?
We do, so our protocol, any live case, we get a central vein. So we're doing it through a central common femoral vein, a 5 French sheath. But typically we do it through a peripheral vein, just at a dose of 140 mics. And we do it over 2 minutes or until we see hyperemia.
What do you look for hyperemia?
So we look for separation of the PDPA, a overall drop in the pressure, and increase in heart rate.
There's some places in Europe that use papaverine for this intracoronary, which I think it makes things a little easier that you just inject it in.
Yeah.
But we've had really good results with adenosine and not a lot of adverse consequences from it.
And do you do it IV or do you bolus?
We do it IV, yeah.
Okay.
I think Jay Widmer in Texas has done some bolus injection of adenosine, but to me, we get steady state hyperemia really easily with an IV infusion.
So here she's, heart rate's up a little bit. You can see a little bit faster. a little bit of separation with the green and red, the PDPA. But usually we see hyperemia about a minute 10, minute 15, 20 seconds. So we'll give it a full 2 minutes.
It's interesting. So her PDPA on a totally normal coronary, there's no atherosclerosis that we can appreciate, is 0.88.
Right.
And the RFR was 0.93. And I think we see this quite a bit, that even in these normal vessels, there's a lot of pressure loss.
Yes.
Yeah, I think we're seeing the effects of the adenosine now.
Yeah, I think we're seeing some.
Yeah.
Sometimes we will go up to a higher dose of adenosine.
Which I think is a good idea.
I think that's probably appropriate. We'll go up to 180.
Yeah, I think the boluses of adenosine we use in the old days because it's to measure in FFR. So it's just a measure on time. But in these cases, we need a sustained effect of the adenosine. So I don't
Just
think the
tap on
boluses,
fluoro. Just make sure. So we always want to make sure your wire hasn't
and
drifted.
the guide.
Your
The guide
guide
has
is
to be-
engaged.
That's very important.
Very, very important. Because if your guide's not engaged, your flows are going to be slower. If your wire is more distal, your flows are going to be pseudo slower.
And the nice thing on the
take longer.
CoroVentus system is it'll tell you when you get that
Yes.
slow injection red box that tells you that your guide might have popped out.
Exactly.
Exactly. It says fault, you know.
All right. I think we're probably pretty close here. I'm going to go ahead and do a hyperemic injection.
So if we can focus on Dr. Sweeney's hands, he's injecting the 3 cc's now.
And so what you notice already, that blue dip, that's more of a dagger as opposed to that slight round. And look at that shift to the left. Pretty remarkable. So I do think we are hyperemic.
It looks like it. Your orange line all the way at the bottom, that's your hyperemic transit time, is way over to the left, like you said.
Yep. So again, I wait for the temperature to get back to close to 0 before I re-inject. And we're pretty much there. And we have adenosine running. But you see that nice sharp dagger versus our resting was more of a hump, like a thermodelusional cardiac output. And that really speaks to the augmentation that her coronaries are seeing here.
So you see that from 2 seconds is down to 0.2 and 0.4. So it's a 10, it's increased by significant.
Take the 0.4 out.
Yeah. So the speed is pretty good, suggesting the microvascular resistance is not there.
So do you inject the 3 cc's quickly, slowly? What's your technique?
As quick as I can.
Yeah.
As quick as I can. I use we use a 3 cc syringe here. We were doing it up at the guide, but it was very awkward the way we were doing it for our hands. We got used to it here. And again, it's just displacement. Up here, I put my palm on it and I inject very quickly, much faster than a cardiac output.
And close the TUI well so you don't get air somehow.
Yeah, I think those curves are pretty good.
They're beautiful. Yeah, you have textbook curves there in terms of the morphology, and then your numbers are all really close.
6.8.
Yeah, I mean, she's, her CFR is augmenting very well. Now we'll do an FFR just for completeness, and that kind of confirms that she does not have obstructive disease. And then the last step, which we have to make sure, is we do a pullback. We look at the pullback gradient, and we make sure that we don't have any wire drift.
Should we start?
Yep.
Pulling back the wire. So I'll expect the jump in the prox LAD.
Yeah, it's probably going to be right around that curve.
Yeah, look at that. It's pretty
there
diffuse. It's recovering slowly but surely.
And
And
there.
now.
Yeah, it looks like a pretty gradual gradient.
Right to 1.
Yeah.
Perfect.
And so do you ever put the wire down the circumflex or do another vessel at the same time?
I don't. I typically start and finish with the LAD.
But
we can.
Yeah, I mean, in the absence of LAD territory.
Doing so, we'd have to stop the adenosine, and unless we can use the resting indices on the LAD.
I have not done a lot of multi-vessel cases. I think there's some publications out there that say that your yield might be slightly higher if you do that, but
no, but you can't, because the resting is the LAD. The resting flow in the circuit is going to be different.
Right.
So we'd have to stop adenosine, let it wear off, and then repeat. So I think in sake of time, we're running kind of on the end side here.
Yeah, she had inferior ischemia and very symptomatic patient. And then we're going to end up with a question mark here. So I will vote to do it if we have the time.
Well, we can do it offline for sure.
Offline, yeah.
Laura.
Yeah.
Okay.
How do you interpret the numbers that you have here?
So the way I interpret
Ready to
this
finish?
is, yep. Beautiful. So her coronary flow reserve of 6.8 is fantastic. So you want to see at least a 2.5 augmentation of your flow with hyperemia. That's where 2.5 comes from, and she's 6. So big augmentation. Her IMR is 20, and the IMR is just the PD with hyperemia, times the PA, and her IMR is 20. So that's below 25,
It's all normal.
very normal. Her resistive reserve ratio, that's 7.8. That's not a newer one, but anything more than, I say 2.7. I don't know what you use for that. If it's less than that, that's more indicative of badness, if you will. But hers is 7.8. So
Yeah, I like your interpretation of the resistive reserve ratio. I think it's prognostic, right? Less than 2.7
yeah,
says that you can't vasodilate properly and leads to bad outcomes, but
Yep.
it's hard to put it in the context of symptoms.
right. But overall, I would say this is a pretty normal study.
I think so. Yeah, it looks that way. Your acetylcholine testing was normal, and then your wire-based testing here is also normal. So good, reassurance for the patient.
Yeah. I think with that, Samita, are there any questions that have come in or anything that you want to ask us?
There's a lot of people online, and so if people have questions, please put them in the chat. My question for you is, what's next for this patient? So she's had quite a bit of a workup so far.
Good question.
Yep. Yeah. Next for me is to do it in that huge circ.
Well,
I think that's
we will do that, but I think the important thing here, I would interpret this stress test as she was a left dominant system. We see that all the time in these diminutive rights. I'm actually reassured, to be honest with you, and I think that in this case, we can peel off the bisoprolol. I don't think there's any evidence of using ranolazine here. Does she need to be on aspirin? She had some athro on her CT, but that's questionable. And just treat her hypertension.
Yeah.
I fully agree with that.
Now that we have a vein, maybe doing a right heart cath and measuring good old hemodynamics.
Yeah, her echo was normal. Her end diastolic pressure was 15.
Yeah.
So
we do quite a bit of that where we add on a right heart cath. We'll unmask some elevated filling pressures, things like that.
Yeah.
Yeah.
And then the next step for me is that I send a lot of these long COVID patients to our pulmonary hypertension group.
Yep.
And they do cardiopulmonary exercise testing and invasive testing. They have other disorders like impaired peripheral oxygen extraction.
Yeah.
But at least you can take ischemic heart disease off the table for this patient.
I do. I agree with that, and I think we've fully assessed her microvascular system as well as both provocative mechanisms, and I think we can safely say that she does not meet that criteria.
Yeah.
Fantastic. Well, I think with that we'll sign off unless there's any other questions that you have, Dr. Moreno, and you have. But I think we can do an offline circ.
Yeah,
we got to let
no problem.
the adenosine wear off a little bit. But I think this was a huge success. We're very happy that we can give her a clean bill of health, a little bit more testing. But other than that, I think until next time, thank you very much for attending. And Dr. Shah, thank you so much for moderating this case.
Thanks, Dr. Sweeney and Dr. Moreno. That was a beautiful case, really textbook presentation. And thanks everybody online for joining. This is a great series, and the next case is going to happen on July 2nd. So these are going to be every other month going forward. So July 2nd at 8 a.m.